Good morning. This is Dr. Cameron Sandifer, and I'm with Dr. Amanda Sell. We are both second-year internal medicine residents at St. Bernard's Medical Center in Jonesboro, Arkansas. Today, we'd like to present a case that we recently had of acute viral pericarditis. We believe that it is relevant because it has a slightly unusual presentation. So, pericarditis is a result of inflammation of the pericardial sac that surrounds the heart. It can be a result of various causes, from infection, drugs, malignancy, injury, radiation exposure, or simply idiopathic. Its incidence is only 0.2 to 0.5% in hospitalized patients. Patients will typically present with a pleuritic chest pain that will improve when they lean forward. It can potentially progress to a pericardial effusion that can be life-threatening if it progresses to cardiac tamponade. So our case is a 27-year-old white male with a medical history significant only for one episode of pancreatitis. He presented to the ER complaining of sharp epigastric and right upper quadrant abdominal pain that radiated to his back. The pain began a few days prior to presentation and was associated with nausea, vomiting, diaphoresis, shortness of breath, and a dry cough. He had no travel or recent sick contact exposure. His physical exam was notable for epigastric and right upper quadrant tenderness without any guarding. His initial vitals showed a temperature of 101.7, heart rate of 111, a blood pressure of 130 over 85, and his oxygen saturation was 96% on room air. His initial lab work revealed a white blood count of 9.3. His electrolytes and kidney function were unremarkable. His liver enzymes were slightly elevated with a AST of 75 and ALT of 95. His total bilirubin was 0.9. His initial lipase level was less than 20. Our suspicion at this time was for cholecystitis. So we underwent a workup including abdominal ultrasound. This showed gallbladder wall edema and mild wall thickening, as well as mild ascites, but no evidence of any gallstones. A CT abdomen and pelvis with contrast was ordered that revealed inflammatory changes around the gallbladder. Again, no gallstones. There was no pancreatic inflammation at all. A follow-up HIDA scan was ordered that showed a patent common bile duct as well as a cystic duct, and there was a normal ejection fraction as well. This ruled out cholecystitis, but interestingly enough, on the abdominal CT, it revealed that the patient had a moderate to large size pericardial effusion. We followed this up with the echocardiogram that confirmed the effusion. There were no signs of tamponade on this. At this point, we went and had further discussion with the patient, who revealed that approximately 1 month prior to presentation, he had suffered a tick bite. And about a week after that, he had some subjective fevers as well as a left-sided chest pain that radiated to his left shoulder. This was accompanied with dyspnea on exertion, night sweats, and a subjective fever. He treated his fever at that time with Tylenol, and it had mostly resolved until about 3 days prior to this presentation to the ER. At this time, we ordered further labs, including ESR and CRP. They were both elevated at 56 and 20.1 respectively. We sent out tick titers that eventually returned negative. We also checked the ANA that was also negative. Unfortunately, the patient elected not to have a viral panel sent out due to cost. Ultimately, the patient was felt to have a viral pericarditis and was discharged to continue taking NSAIDs and colchicine. A follow-up echocardiogram was performed 1 month later that revealed only a trace pericardial effusion with almost complete symptom resolution. So, acute pericarditis is a common disorder involving the pericardium. It's diagnosed in approximately 5% of patients who arrive to the emergency department with non-ischemic chest pain. Pericarditis has a number of etiologies I mentioned before, also to include autoimmune disorders and post-myocardial infarction trauma. However, nearly 80 to 90% of cases are idiopathic and presumed to be viral in origin. It's a clinical diagnosis requiring two of the following findings: typical sharp pleuritic chest pain, a pericardial friction rub, a EKG finding, typically widespread ST segment elevation, or a new or worsening pericardial effusion. During the workup for the patient's abdominal pain, we did find the moderate sized pericardial effusion. In addition, a substantial friction rub could be heard on physical exam. His abdominal pain was ultimately determined to be likely secondary to pericarditis. Approximately 95% of patients with acute pericarditis presented to the ED with chest pain. Our case was unusual given our patient's predominant complaint was abdominal pain, which to our knowledge is not a common mode of presentation for pericarditis. It is important to consider pericarditis in the initial differential for abdominal pain because a delay could result in a worsening effusion leading to cardiac tamponade. So in closing, pericarditis is very common worldwide. It's typically going to present with chest pain. You can have other nonspecific signs and symptoms. We wanted to present this case because although rare, pericarditis can present with abdominal pain. Fortunately, in our case, we found the pericardial effusion incidentally on imaging, which helped lead us to the correct diagnosis.